following KMR advice on YouTube, especially our medical students tuning in from India, we have a really important mechanism to break down today.
That's right. We're looking at carbonic anhydrase inhibitors.
Specifically, acetazolamide and how it works inside the kidney. We'll take this nice and slow, step by step, really making sure it's clear.
Absolutely. The goal is to map out exactly what this drug does, sequentially, once it's in the body.
Okay, so let's start at the very beginning. Step 1.
Well, step one is simply giving the drug, the administration of the carbonic anhydrase inhibitor.
Like acetazolamide, our example here. Okay, administered, then what? Where does it go to do its job in the kidney? That's step 2, isn't it?
It is, and the location is key. The proximal convoluted tubule, the PCT.
Ah, the PCT. A major site for reabsorption,
A
right?
huge amount happens there, yeah. So the drug needs to get to the PCT to work.
Okay, so acetazolamide is in the PCT. What's its direct target? Step 3.
Step three is inhibiting an enzyme, the carbonic anhydrase enzyme. It blocks it.
Carbonic anhydrase. Why is blocking that enzyme in the PCT such a big deal?
Well, you see, carbonic anhydrase is crucial for the PCT cells to make hydrogen ions, ions.
Right.
So step 4 follows directly. Inhibit the enzyme, and you get fewer hydrogen ions inside the cell. The availability goes down.
Okay, fewer He ions inside the PCT cell. Got it. And step 5, that impacts reabsorption. How does that link work?
It links to a transporter. There's a sodium-hydrogen exchanger on the cell membrane facing the tubule. It usually swaps sodium in for hydrogen out.
Okay, a swap mechanism.
Exactly. But if you don't have enough HU inside the cell to swap out, because carbonic anhydrase is blocked,
And the exchanger can't bring as much sodium in.
precisely, the exchange slows down. So less sodium, NIU, gets reabsorbed back into the body from the tubule fluid. And bicarbonate, HCOU, reabsorption is linked to this too, so less bicarbonate gets reabsorbed as well.
Ah, I see. So the drug makes us lose more sodium and bicarbonate into what will become urine, which leads nicely into step 6, I imagine, increased excretion.
You got it. More NIU and HCOO staying in the tubule means water stays with them too, due to osmosis.
So you get excretion of sodium, bicarbonate, and water. That's the diuretic effect, right? Although it's usually described as mild with these drugs.
It is generally a mild diuretic effect, yes, but the key consequence isn't just the water loss.
Right. Step 7, the changes to the urine itself and, more importantly, the body's acid-base balance.
Exactly, because you're excreting more bicarbonate, which is a base, the urine becomes alkaline. Its pH goes up.
Alkaline urine. Okay.
But, and this is critical for anyone watching KMR advice, losing that bicarbonate from the body overall can tip the acid-base balance.
Or it's acidosis.
Yes. It causes a risk of metabolic acidosis in the patient. The blood becomes more acidic, even though the urine is alkaline.
That's a super important point, alkaline urine, but systemic metabolic acidosis risk. Which brings us to step 8, what we need to do about it clinically.
Monitor the patient. That's step 8. Because of these shifts, you absolutely have to keep an eye on their electrolytes and their acid-base status through blood tests.
Makes perfect sense. Okay, let's do a quick recap for everyone on KMR advice.
Good idea.
So, acetazolamide, the carbonic anhydrase inhibitor, gets administered, step 1, acts in the PCT, step 2, inhibits the carbonic anhydrase enzyme, step 3.
Which leads to fewer hydrogen ions, step 4, reducing sodium and bicarbonate reabsorption, step 5.
Resulting in increased excretion of NaO, HCOO, and water, a mild diuretic effect, step 6.
And causing alkaline urine, but crucially, a risk of metabolic acidosis, step 7.
Which is why monitoring is essential, step 8.
It covers the sequence nicely.
Great. So this breakdown, we hope it's really helpful for your studies. Remember, this is for you, our viewers on KMR Advice.
Please do share this with classmates if you found it useful. And subscribing to KMR Advice, hitting that bell icon, means you won't miss out on future deep dives like this.
Definitely. And maybe a final thought to leave you with. Think about the clinical scenarios where knowing this specific sequence, understanding why the acidosis happens alongside the diuresis, is absolutely vital for managing your patient effectively.
That's a great point. Understanding